It's incredible, it's impressive, and I had the fortune of caring for this young man in our trauma bay at Grant, and we'll talk about it. So if we could start, thank you.
Name's Andrew Gale, and I'm from Oregon, Ohio, which is a suburb of Toledo. Prior to my injury, I was definitely an outdoorsy person. The last 2 summers, I worked at YMCA of the Rockies in Estes Park, Colorado, and worked at day camp, so we were outdoors 8 hours a day with camp. My accident was a spinal cord injury. I was on a camping and hiking trip with my friends at Lake Hope State Park in southeast Ohio, and Sunday morning after a weekend hiking, before we went home, we wanted to just go for a dip in the lake. And so I was running into the lake. I'd seen a few people do it before, and as I was getting to where I thought the drop-off was, I decided I'd jump, and instead of jumping out like I was planning on, I ended up jumping up too high, and I started coming forward onto my head, and immediately I realized this isn't right. This isn't how I'm supposed to be landing in here. And so I just started thinking, like, I mean, everything's rushing through the head, like, what's going on? What's going to happen? Should I put out my arm? Would I fracture my arm? Well, I mean, that probably would have been a better scenario, because when I came down, there wasn't the drop-off, and I fractured 2 vertebrae, and it was burst fracture and C7, and I had Jefferson fracture on my C1. So from there, my friends took me from the water. They actually both have wilderness first responder certifications, so thank God they stabilized me and made sure not to be bobbling my head all over the place. And they immediately started taking vitals while another friend called for the ambulance. And ambulance came, they started doing vitals and everything, got me on a stretcher and took me over about a mile down the road where we caught up with Life Flight. So once we got to the helicopter, I immediately just thought, this is awesome. I'm going up in the sky. It's like being on the mountains again. Like, that's immediately what I thought. And so I was just ecstatic to see that I was going to get on a helicopter, beautiful blue skies. And later the flight medic ended up saying, yeah, I didn't know if you realized the severity of your injury because you were so happy. You were like, you clearly, to me, you just didn't understand it. And I had an idea, and I could have let myself think about it, but I just, at that point, it was, you know, this is going to be what it is. And so just go through the rounds, let them figure out what it is, let them do what they need to do. The basis of everything is that you can either deal with it, take something from it, and move forward, grow as a person from it, or, I mean, a situation like this, you can sit and wallow in your pity, or, you know, emotional things. You can just sit there and grieve on it forever. Oh my gosh, this person said this person did this, I didn't get to do this. But at the end of the story, like, no matter what, everything's helping you move forward. Everything's helping you become that better person, that person that's growing into just this beautiful being. And it's something incredible, I think. I'm walking, I'm doing therapy 3 days a week, 2 hours minimum with PT, and then typically an hour of OT as well. And so with that, it's lots of leg movement. We're really pushing how far I can walk. Last weekend I did my first full mile, and so that was an awesome accomplishment. And yesterday we walked unassisted for 320 feet, so that was incredible. But yeah, so that kind of stuff has really increased my activity level. I can even tell just from those walks of a quarter mile, half mile, I'm sweating, I'm tired, but that's to be expected after spending so long in a chair, in bed. And so yeah, it's definitely picked up quite a bit. And even in the last week or 2 weeks with friends getting off school and things, going out more, doing more. And it's kind of awesome just getting back to living normal life. And Sunday, I went with a friend, and she was just like, it's kind of surreal. I mean, except for your poles sitting next to you, you wouldn't think that this happened to you. And so it's kind of awesome in that aspect. But yeah, just getting out a lot more, and it feels good. I can't thank you enough for your service and what you're doing. It was very prompt on getting the ambulance down there and then getting over to the helicopter and the firefighters there clearing the road and stuff to get the ambulance through, because it was very small roads there in the state park. And it was just, I can't thank you enough for the promptness and being there and keeping calm through it, keeping me calm through it. It's just incredible what you guys do. And I mean, to just take on fresh injuries and say, we'll stabilize best we can, get them to the doctors. I mean, that's a tall task, and that's something that you don't know day to day what your job is going to be exactly. And so that's an incredible task to take on, and just I can't thank you guys enough for doing that and putting everything out there that you have and all the knowledge, all the equipment. It's just an awesome system. So.
Truly remarkable. I'd like to invite at this time Andrew and his mother Teresa to come up, say a few words.
This is Mother Teresa, and then Father Craig and my sister Sarah. All right. Well, yeah, I guess first I'd just like to say thank you again to everyone. It's an incredible system with OhioHealth and all the emergency responders and everyone around here. It's, oh my gosh, just I can't thank you guys enough for what you did for me and what you guys do for people every single day. I'm sure a lot of you don't get to see your patients afterwards, but every single one of us owe so much to you. So I'd like to thank you all for that again. I guess I didn't talk too much about my future, so I figure I'll start out with just a little bit of where I'm going in my life and what I'm doing. I'd said that I kind of started doing a little bit of free walking at therapy, and since then I've been approved for 1 cane walking, but had a 2.5-hour drive, and I still have a nice little side effect of tone and spasms, so figure extra stability of 2 is good. But so I'm working on getting to 1 full time, and we've done a lot more walking without anything at all, and that's the ultimate goal from my PT, is to get me back to walking unassisted. And I mean, that's such an incredibly tall task to work for, but I'm up for it every minute, every day, because just where I came from, there's no doubt I'm going to go for it, for just chase it, and chase it to the ends of the earth. But yeah, so that's this summer, and 3rd week of June, I'm returning to Colorado as a floater at my camp. That place, it changed my life, and it's crazy because this whole path and journey that I've been on came from before all the way through the whole system of the people that I worked with and everything. Colorado changed my life, and so I'm excited to get back there, start pushing myself on the hills, and from day one, whether it was going to be a body sled or whether I was hiking, I was going to get up to a mountain again. That was my drive from day one. So then I'm returning to school in the fall, and it's such an exciting time. I've been seeing all my friends, keeping up with them. Just so excited to return to getting life back together, putting everything together. Ultimate goal is to get back into outdoor recreation as a management or supervisor position. Originally, I wanted to be a guide in the field, possibly I was thinking loosely about going into wilderness medicine, but it's not really in my future anymore. But I still just want to get people outside because without a doubt, it's changed my life just being outside and seeing all the wondrous things and giving me something to chase and work towards. I've finally started driving again, which is a beautiful thing, let me tell you. Being able to get out, oh my gosh. Again, that's just all back to getting things back to normal, and it's such an incredible thing. And, people will say, and like, you're such an inspiration, and you've done such incredible things, but realistically, to me, I find inspiration so much from the people who do incredible tasks every day, from the people that I've been hooked up with through many of my caretakers through this process who are in chairs full-time, or, even the caretakers and what they do on a day-to-day basis. They're all things that inspire me because I don't believe that I could do it at least as well as they're doing it. And, people may find inspiration from my story, but so many people out there have inspirational stories. And, it's just, if you look at it, what I've decided through all this is, especially in inpatient, I saw it, is that life is about perspective and being able to come through things, just looking at the positives and taking positive energy from the people around you, because each of us are on such an incredible walk and going on such an incredible journey if we just take the time to look at it and realize and learn from each situation, because that's ultimately what we can do. We can't change anything that happened, and that's how I'm taking this, is that, yes, it happened, but now, what I love to do is go to people and share my idea of this journey and how it's not bringing me down. It's not slowing me down. Yes, physically, I'm less. I can't do as much physically, but I'm still me, and I can still have an impact on people. And, imagine if it blew my mind how many people were positive and just expressing to me how they felt when I was injured. And that's something that I think all of us can use on a day-to-day basis, is just sharing the positive things we think towards other people. Too often we get caught up in the now and the us, and we don't share what we truly feel or think about people. And that's something, especially that I'm glad I got to be here, is to share with you guys how incredible a job you do every day and how spectacular it is, because without you guys, who knows where I would have been. And it's just, if we share those positive things, look at the positive things with perspective, then we can all be so much more, and just to continue to grow as a person and an individual. That's something that else has kind of helped me out, is the mentality. I know I said on there about the helicopter ride. I loved it because it reminded me of Colorado, being up in the clouds, and it was just such a beautiful moment. But ultimately, I think a large piece of what helped me recover so well too is the perspective, and being able to see other people and say, they're living incredible lives, I can do it too. And I think that from day one, coupled with just something to strive towards, something to work towards, has really helped bring me through this in such a positive way. I guess I'll let my family take the floor if they would like to speak for a minute. Sure. Anyone? Okay.
I just want to say I've been so much appreciative of all the wonderful things the whole group has done for my son, Andrew. We're not sure where he gets his motivation and his personality, but somewhere down the road in our family life, I guess we gave him something reasonably to work with. I work at a nuclear plant in north coast of Ohio, and I can relate just very little to what you all do for a living. 3 times a year, we get told that we're going to have a drill. And we know it's coming. We have no idea what it's going to be, much like the random jobs you guys have to do every day. But when we get to that day and actually have to do that work, we are so nervous. We know what we're doing, but it's never planned. It's always out of the box thinking immediately. And you guys do that every day on your job. And I'm just so amazed that you guys are able to do that day after day. It would be extremely nerve-wracking for one of us to do that. So I want to thank you very much for the job that you guys do every day.
And I just wanted to say 2 things. I wanted to thank you all for your head for what's in your head and your heart. Throughout the whole process, your hearts were so big. I'm sure they are for all the patients and everyone you pick up every day. And you treat them as if they were one of your family members, and you treat them that well. So thank you for all of your big hearts, and you have to have a big heart to do this job. And what's in your head, thank you for remembering everything you've ever learned and for taking each experience and building on that to help the next person even more. So I just wanted to say thank you as well.
Well, I'm not really the speaker in the family, but all I really want to say is just thank you from the bottom of our hearts. It's just meant so much.
And I guess to expand on what my sister said a little too, I really should have mentioned that too. Don't ever be afraid to keep up with a patient, follow them a little bit in the hospital, because that's one of the incredible things that I found. And the support from the nurses, from the emergency responders, flight medics, everyone through the entire process who, I mean, everyone, it seems like so many people would come up and check or say they're talking to this person or that person who saw me. And that, I think, is something that I wasn't able to vocalize so much while I was in the hospital and in the process. But it really made such an impact having these people support me who were outside of my family, who I didn't even know, and seeing that they actually cared. And I wasn't just an average patient, average person. You know, they actually genuinely cared about what the process was, what was going on, how things were going. And I mean, that is, I can't even express my gratitude enough. Between those things and the people that I've been connected with from these people is just absolutely incredible. So never, ever be afraid to go see a patient or keep up with them after you hand them off. And again, we just thank you from the bottom of our hearts for everything. It's just such an incredible experience. And the things that you do, I mean, I don't think anyone outside the field can relate to it. Such a tall task what everyone does here. And just thank you so much from the bottom of our hearts. Appreciate it.
It's truly amazing. Do we have the emergency responders from Benton County EMS, MedFlight, and associates from Grant who cared for Andrew? If so, we'd love for you guys to come up and take a bow, because this is a remarkable story. Andrew and Teresa and family, thanks so much for being here, and special thanks for all you responders. It's truly about team, isn't it? Well, as I had told you guys before lunch, now is the interactive portion of the program. We had hoped that Akram Mahmood, who was our spine surgeon, would be able to give us a presentation, but unfortunately the OR calls. So this is my partner and my associate medical director at the Grant ED, Dr. Dave Schmidt. And what we're going to do is involve you guys in a discussion about my favorite topic in emergency medicine, airway, because it's always ABCs. So in my practice, I've been practicing for 30 years now, the two major changes that I have seen really in probably the last 5 years have really revolutionized airway care and patient survival are twofold. First is non-invasive positive pressure ventilation, BiPAP and CPAP. If those of you are as old as me, probably one or two of you out there, back in the old days, you get a patient in extremis and CHF, just full to the gills, and we'd throw a nasotracheal tube in and give him some nitrates and just kind of let him go. And, you know, we probably intubated 90% of those guys. And we were just praying that they were hypertensive so we could play with it and not have to start CPR on them. And with the advent of positive pressure ventilation, we have saved so many people from being intubated and all the downsides and the length of stay in the hospital and the hospital-acquired pneumonias and things like that. So it's been revolutionary. So I'd like a show of hands for my medics. Who's using CPAP, BiPAP in the field right now? You guys can show me. All right. Who is not? You guys need to get on board. Dave?
Yeah, as far as non-invasive positive pressure ventilation, it really is kind of the way to go about things. You think about cardiac resuscitation as a whole, where we've been and where we're going to now. Really the two big things now that help us in terms of outcomes is electricity and compressions. The thought of immediately, establishing an airway with endotracheal tube is kind of a thing of the past. That doesn't, take away the priority of an airway. Non-invasive positive pressure ventilation, some, call it CPAP, BiPAP, or, bag valve mask with a PEEP flow valve, all great things. Some passive things that, we've seen in the last year to bridge off non-invasive positive pressure ventilation is this whole concept of passive oxygenation or apneic oxygenation. And it seemed really strange to me the first time I heard about this. This is somebody that's not breathing, they're not ventilating. We have a good idea that we want to intubate them. And so the thought process has been, place them on a nasal cannula, as high as it'll go. 15 liter, if you can take it higher, do it. And use that with the 100% non-rebreather as a means to oxygenate somebody as a bridge until you make that definitive step to put in a definitive endotracheal tube. So what I commonly do when I have somebody that we want to intubate, oftentimes if it's an overdose patient, somebody that's sedated, you and I, if we had 15-liter nasal cannula cranking, we would be very irritated. But it's very helpful in somebody that's unresponsive. You turn up 15-liter on somebody that's maybe, has got alcohol that's a little bit up there, they've got co-ingestion. It really gives you a good indicator of how depressed their mentation is, wakes them up perhaps a little bit. If it doesn't, then you know how soon you need to act. So what typically I do, while we're getting things arranged to, get your laryngoscope and suction, is to put that nasal cannula on, turn it all the way up. Initially, when I did this, the respiratory therapist looked at me like I had 4 eyes. But you're putting a nasal cannula on, turning it up, and then putting 100% non-rebreather on them until you're ready to go. And from the times I've done it, I've never seen anybody desat, never seen anybody go below 90%. It's a very relaxing thing now just in terms of getting prepared to intubate somebody. So that's been a big thing in the last year that we've seen in the emergency medicine literature as far as airways, this whole concept of passive or apneic oxygenation. When we talk about non-invasive positive pressure ventilation, positioning is important. As our population gets larger, sitting somebody up does an incredible thing in terms of decreasing the amount of atelectasis in those lungs from being collapsed. So positioning's big, sitting them up. If they're a trauma patient, you can place them in reverse Trendelenburg. All measures to help you with your ventilation and oxygenation.
Do you guys have any questions about pre-hospital positive pressure ventilation? Are there any concerns, any issues or problems you've had with setting it up in the field?
Who's using in terms of video laryngoscopy is something that is catching hold? How many people are using video-assisted devices for intubation? Looks like about half the crowd there. We use a gyroscope. There are several others that are out there. Some of the literature has shown that, maybe in 5 years, the concept of a laryngoscope will all be forgotten as we look forward. That it really has changed our way in terms of that difficult airway, having that monitor right there to assist us to be able to intubate somebody. So I know the King airway is one that a lot of folks use. I think they're pretty amazing products out there that, again, in 5-10 years, we'll look at that laryngoscope perhaps and just think of it as a thing of the past. Anybody have any questions overall in terms of, the concept of whether to intubate or not, bridge that gap, 100% non-rebreather?
Yes, sir. Right.
That high flow oxygen, we're allowing PCO2 to drift up. The key is to get oxygen in, and from the studies they've done, you turn that nasal cannula on and it's giving them just as good oxygenation rather than actually bag valve mask with ventilation. So it's an incredible bridge if you have time just to turn that nasal cannula up, turn it up as high as you can go. And some are saying now that if you have 40 to 50 liters of that, that's the best way to go.
Yeah, one of the things that those of us who have done a lot of pre-hospital bag valve mask is that we stop and think about it. You're insufflating the stomach, and the stomach gets bigger and bigger and bigger. Basically, your pulmonary function is worsening because of the pressure of the gastric distension. And we had a miserable airway a couple days ago in the ED when the patient had an overdose and had alcohol and started bagging, and all of a sudden there's just emesis spewing through the nose, through the mouth, and you're suctioning. We've all seen that. And this is an advantage for that. And again, the concept that Dave pointed out is something that more research has shown, that passive CO2 rise really isn't that big a deal if you're going to do your airway. You're going to have more time to get your definitive airway. If you get that O2 sat high, you're going to have more time to do what you need to do, and you're not worried so much about the rise of CO2. It's really maintaining that oxygenation, and again, you're not distending the stomach, you're not going to be puking all over the place, and it's a much better way to go rather than slamming it like we all do, because you're in a stressful situation, the patient's going down the tube, and your inclination is to overbreathe and hyperventilate, and that stays away from that. So hopefully that answers your question. Yes, sir. if you have to bag, you have to bag. If the patient's apneic, you're bagging them. But somebody who is breathing, put them on 100% mask, and you crank up your nasal cannula as high as you can possibly get it. And it's in, you know, if you got a bag, you got a bag. But if the patient is breathing, then that's a good way to go. Yes, sir.
Would you do that if you know this patient has a history of COPD?
Yeah, I would say, I mean, this is a bridge to establishing a definitive airway, and it's something that is going to be helpful for a 5-minute period. So this is a brief period of time that we're cranking up a nasal cannula, giving 100%, non-rebreather mask. You know that you're going to establish some definitive airway. So if the PCO2 rises, they're a COPD patient, that's fine. We'll deal with it. The key is oxygenation in that short period of time. So these is really in the people that you have a pretty good understanding that they need to be intubated. So if you see them in the field, you think, hey, this is something, they're a head injury or it's overdose, you have a good idea that they're going to need to be intubated. This just allows you the time to just, concentrate on other things, establish an IV, getting some fluids going, you hook your nasal cannula up in your 100% non-rebreather, and it just makes for a much more calm resuscitation. I can just speak from, we get somebody in the emergency department, and it just makes things much more pleasant. You see that pulse ox never go below 95. And I was very, very skeptical initially when I heard about this, and this has all really been in the last year, but I'm sold. So I tell the respiratory therapists that we have a splitter. We have 2 oxygen, intake valves, so we just hook them up. Any other questions? Well, if it isn't, it should be. If you're not using it, then, you're kind of behind the 8 ball on that. We have, the speaker last year was a big proponent of end-tidal capnography when he was in LA County. We use it in the emergency department, and I can say that a year ago we were not using end-tidal capnography. It's very helpful in the trauma patient. They come in the old days, you tube them, 20 seconds later, you realize you're not in the trachea, you're in the stomach. 10 seconds later, the patient aspirates, and then you're suctioning, and then you get desat. And, Dr. Gabriel, we've all been there. So this way, when we intubate somebody, we have that end-tidal just like that, then we don't have that period of time where we're questioning whether, they're intubated or not. We don't have to worry about aspiration. So it's really been helpful. So if you're not using it, something that should be a priority in terms of quality of care for your patients. We also use it for procedural sedation. We have a shoulder dislocation, a complex laceration. We will hook up the patient to end-tidal to get CO2 monitoring. If we'll use any combination of drugs for sedation, ketamine, propofol, etomidate. It just makes it a much calmer, on the part of you as someone managing their airway.
Yeah, I would completely agree with that, and I think that it is something that should be standard. As Dave said, in the past, patients have gotten into a lot of problems, particularly in the GI lab or in the electrophysiology suite, because they had them on O2, their O2 sat was fine, but what wasn't appreciated is that they were becoming hypercarbic. So all of a sudden, you think your patient, you're not paying much attention, you're just looking at the monitor, not really watching the patient, really not breathing very well. CO2 starts going up, and all of a sudden you have an arrest. So with the capnography device, we're watching it, and we're, if the patient starts getting in a little bit of issue, then we can start assisting the ventilations, and it is just made for incredible improvement in patient safety, particularly when there's no such thing as conscious sedation, it's unconscious sedation. And that's what our anesthesiologists have always pointed out, that if you're not good with doing an airway, you'd better not be doing, quote, conscious sedation or unconscious sedation, because you'd better be able to step in if that patient starts getting into respiratory problems. And that was part of the issue. Our GI guys were not particularly good. Our cardiologists, they wanted to do their procedure. They weren't paying too much attention to the patient, and had some bad issues. So yes, I think you're absolutely correct. That should be the standard across the board. So that's part one, the pre-hospital use of CPAP, BiPAP. Now, in my career, as I said, I've been doing a long time. I trained at Cincinnati in the mid-'80s, and we were one of the first 2 or 3 places in the country that went to RSI, okay? Because beforehand, a lot of the intubations were done nasally. If you talk to the old medics, it's like, well, yeah, I just fired down the nose and nothing to it. And well, what you don't realize is that our intensivists hate nasotracheal intubations, because every one of those guys gets septic, they get all sorts of nasal necrosis, and they get just malignant sinusitis, and it's just not good. So standard of care really, as I've told my guys in Washington, really is not to do nasotracheal intubation. Do place king tube, whatever, and let me, with all my armamentarium in the ED, do the definitive airway. It's like we're always trying to be macho. It's like, yeah, I can get that tube. Well, it's like, is that really the right thing to do for the patient? You got to do it for the right patient in the right way. So how many guys and ladies in this room are using RSI or using paralytics in the field? Can I see a show of hands? Wow, that's impressive. That's, 2 years ago, it was like 2 or 3. And as a medical director, I can tell you that it's one of our continuous discussions with my guys. It's like, the guys that fly in med flight and the guys that do work in the ED are very comfortable with RSI. But my fear is that one of our inexperienced medics who is not able to do a surgical airway, if the patient gets into trouble, he can't tube them, that we're going to kill patients in the field. So it's still, kind of a very brisk point of discussion as far as pre-hospital use of RSI. So with saying that, RSI is still, to this time, standard of care for doing intubations. There's no question about it. It's the best way. Paralyze the patient, use succinylcholine, use vecuronium, use rocuronium, whatever. Use your other agent to sedate the patient before doing that, obviously. But the biggest change that we've seen in the last few years, and we're seeing, and is going to be, as Dave said, probably in 5 years standard of care, is that good old direct laryngoscopy is going to be like nasotracheal intubation, I think. I think it's going to be all video laryngoscopy. And the foremost emergency medicine expert in airway management, Dr. Ron Walls out of Boston, who teaches the difficult airway course, has basically said that in his mind, DL is going to be obsolete. I don't agree with that. I think it's always going to be your rescue device, and I tell my young guys and the residents that come through is get used to using the video laryngoscopy. Get used to it. Use it on normal people, because then when you get the airway from hell, you're not using it for the first time. So I think Dave asked a show of hands. How many people are using the King Vision or pre-hospital video? That's, again, very impressive.
That period of time where we're questioning whether, they're intubated or not, we don't have to worry about aspiration. So it's really been helpful. So if you're not using it, something that should be a priority in terms of quality of care for your patients. We also use it for procedural sedation. We have a shoulder dislocation, complex laceration. We will hook up the patient to, Untitled to get CO2 monitoring. If we'll use any combination of drugs for sedation, ketamine, propofol, etomidate. It just makes it a much calmer, on the part of you as someone managing their airway.
Yeah, I would completely agree with that, and I think that it is something that should be standard. As Dave said, you know, in the past, patients have gotten into a lot of problems, particularly in the GI lab or in the electrophysiology suite, because they had them on O2, their O2 sat was fine, but what wasn't appreciated is that they were becoming hypercarbic. So all of a sudden, you know, you think your patient, you're not paying much attention, you're just looking at the monitor, not really watching the patient, really not breathing very well. CO2 starts going up, 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 and all of a sudden you have an arrest. So with the capnography device, you know, we're watching it, and we're, you know, if the patient starts getting in a little bit of issue, then we can start assisting the ventilations, and it is just made for incredible improvement in patient safety, particularly when there's no such thing as conscious sedation, it's unconscious sedation, and that's what our anesthesiologists have always pointed out, that if you're not good with doing an airway, you'd better not be doing, quote, conscious sedation or unconscious sedation, because you'd better be able to step in if that patient starts getting into respiratory problems. And that was part of the issue. Our GI guys were not particularly good. Our cardiologists, they wanted to do their procedure. They weren't paying too much attention to the patient and had some bad issues. So yes, I think you're absolutely correct. That should be the standard across the board. So that's part one, the pre-hospital use of CPAP, BiPAP. Now, in my career, as I said, I've been doing a long time. I trained at Cincinnati in the mid-'80s, and we were one of the first 2 or 3 places in the country that went to RSI, because beforehand, a lot of the intubations were done nasally. If you talk to the old medics, it's like, well, yeah, you know, I just fired down the nose and nothing to it. And, well, what you don't realize is that our intensivists hate nasotracheal intubations, because every one of those guys gets septic, they get all sorts of nasal necrosis, and they get just malignant sinusitis, and it's just not good. So standard of care really, as I've told my guys in Washington, really is not to do nasotracheal intubation. You know, do place a king tube, whatever, and let me, with all my armamentarium in the ED, do the definitive airway. You know, it's like we're always trying to be macho. It's like, yeah, I can get that tube. Well, it's like, is that really the right thing to do for the patient? You got to do it for the right patient in the right way. So how many guys and ladies in this room are using RSI or using paralytics in the field? Can I see a show of hands? Wow, that's impressive. That's, you know, 2 years ago it was like 2 or 3. And as a medical director, I can tell you that it's one of our continuous discussions with my guys. It's like, you know, the guys that fly in med flight and the guys that do work in the ED are very comfortable with RSI. But my fear is that one of our inexperienced medics who is not able to do a surgical airway, if the patient gets into trouble, he can't tube them, that we're going to kill patients in the field. So it's still, you know, kind of a very brisk point of discussion as far as pre-hospital use of RSI. So with saying that, RSI is still to this time standard of care for doing intubations. There's no question about it. It's the best way. Paralyze the patient, use succinylcholine, use vecuronium, use rocuronium, whatever. Use your other agent to sedate the patient before doing that, obviously. But the biggest change that we've seen in the last few years, and we're seeing, and it's going to be, as Dave said, probably in 5 years standard of care, is that good old direct laryngoscopy is going to be like nasotracheal intubation, I think. I think it's going to be all video laryngoscopy. And the foremost emergency medicine expert in airway management, Dr. Ron Walls out of Boston, who teaches the difficult airway course, has basically said that in his mind, DL is going to be obsolete. I don't agree with that. I think it's always going to be your rescue device, and I tell my young guys and the residents that come through is get used to using the video laryngoscopy. Get used to it. Use it on normal people, because then when you get the airway from hell, you're not using it for the first time. So I think Dave asked a show of hands. How many people are using the King Vision or pre-hospital video? That's, again, very impressive. There are airway courses that will help you with that, and again, as you guys all know, practicing on the mannequin ain't the same thing as having it with a patient that's going down the tubes. And the more you practice, the better you're going to get. As Dave said, we use the glide scope. It's a little, my kid could probably do a better job than I can because he does all the video games and can do all that three-dimensional stuff. It's like I'm looking there and I'm thinking, wait a second, I'm used to looking down here, and all of a sudden I'm looking at this slide. So it takes some practice. But again, I think that it's going to be the standard in 5 years from now.
Yeah, I mean, you look forward, our patients are becoming more complex, they're becoming larger, and as a result, the airways have become more difficult. So this is going to be all that much more common, video-assisted devices. It's going to be the norm, the standard of care.
Yes, sir. That's a great question. I would say as far as that goes, very, very minimal. I mean, sucks is still the standard of care for RSI. However, we in the inner city have an enormous population of people who have chronic renal failure or on dialysis. And I'm much more concerned about hyperkalemia in these people that are in arrest or near arrest than I am the other issues that you brought up, because those things are really rare. Malignant hyperthermia is very rare. But if you have concern about hyperkalemia, you can absolutely kill the patient if you give succinylcholine. There's no question about it. So basically, rocuronium is a much safer drug. There are a lot of facilities in the country that have taken sucks off first line, are using rocuronium. It's non-depolarizing. You're not going to have hyperkalemia. You're not going to have the muscle contraction. It takes just a bit longer for it to set up. But, the bottom line is if you have adequately pre-oxygenated the patient, an extra 30 seconds to 45 seconds isn't going to make a big difference. So I would say that the safer way to go is use rocuronium when you don't know about the patient. So if you don't have rock, if you are doing pre-hospital RSI, you need to have rock as well as sucks if you're going to do both. It's definitely safer.
0.6 to 1 milligram per kilo, that's all we use in residency. So when I first started 10, 11 years ago, we did more of succinylcholine. But, certainly with what Dr. Gabriel said, with all the renal failure patients that we have, the big dilemma that we have is knowing whether that K is 6.8 and whether succinylcholine is going to exacerbate things. So good piece of history is to know, hey, do they have a AV fistula? Do they have a catheter coming out of their chest? Are they a renal failure patient? And if so, if they need an airway, take good consideration for rocuronium, 0.6 to 1 milligram per kilo. Usually give them 40 milligrams of rock, 40 to 50, and you're good.
Like I said, love this to be interactive. You guys have any other questions? Well, if not, I apologize that Dr. Mahmood was not able to make it, and hopefully this was of some value to you guys. Thank you very much.